Okay, in the interest of time, I think we'll go ahead and begin. I'm Arne Kumigai, Vice Chair for Education for the Department of Medicine. And we are here this week with a special lecture, the Wendy Levinson lectureship. And I'll introduce our speaker in just a moment. I'd first like to start off with the land acknowledgement. We would like to begin with an acknowledgement on the land on which we work, study, and live. We recognize that many indigenous nations have longstanding relationships with the land on which the University of Toronto's Department of Medicine work is conducted. We acknowledge our presence in the traditional territory of many indigenous nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Today, this land is home to many diverse First Nations, Inuit, and Métis peoples, and we are grateful to have the opportunity to live, work, and gather on these territories. It is important to note, however, that land acknowledgements are only a starting point for larger conversations. More concrete acts of restitution transformation are needed to address underlying inequities and blatant discrimination in the distribution of resources between Canada's First People and settlers. Thank you. Just to give a very brief background on the Levinson Lecture. So this lecture was created in 2015 and named after Dr. Wendy Levinson, who is the former chair of the Department of Medicine, and was designed to recognize a senior member of the University of Toronto's Department of Medicine for outstanding career achievements in medicine that also encompass research, leadership, and education, as well as extraordinary care or extraordinary contributions to patient care. So you may recall that in the past, we've had a number of different lectures. So we had Ian Tenick, Jay Keystone, Michael Hutchinson, Sasha Bhatia was for quality improvement in 2019, Tony Lang, most recently Isaac Odame and Ed Etchells were the most immediate past presenters. This year we have the absolute pleasure and privilege of naming or providing this chair to Francis Shepard of the Division of Medical Oncology at Princess Margaret Cancer Center. Dr. Shepard holds the Scott Taylor Chair of Lung Cancer Research and also the rank of University Professor at the Faculty of Medicine, the University of Toronto. She has had many clinical trials, and I don't think I need to go into detail about this. She is an internationally known for both clinical and translational research that have really fundamentally changed treatment and outcomes for lung cancer patients at a global level. She's chaired a number of different lung cancer committees, has been the past president of the International Association for the Study of Lung Cancer, as a member of the board of directors of the American Society of Clinical Oncology and the European Organization for Research and Treatment. She has received a number of different awards, including the Royal College's Whiteman Award, a Queen Elizabeth II Diamond Jubilee Medal in honor of her research, as well as the prestigious Gardner Whiteman Award. She received the Order of Ontario in 2007 and became an officer of the Order of Canada in 2018. She was also the 2023 Canada Society's Cancer Society's Lifetime Commitment Award awardee, and she has honorary doctorates from York and from the University of Ottawa. She has mentored many postdoctoral researchers. She has co-authored or authored over 600 publications and many book chapters. And on this note, I could actually go on probably all hour with all of her achievements, but we'll keep it short, and I'll turn it over to Francis. So Francis, please. Thank you.
Hey, I am sharing my screen. Can you see it? Okay, thank you very much, Arno. It's actually a great honor for me to, I'm trying to move forward here. Let's see what happens. Yes, it's a great honor for me to be presenting this for Wendy Levinson. I'm sorry actually that she can't be here, but she really did look after our department very ably for many years. So what are my objectives? For you to understand very briefly a bit about the demographics of lung cancer, but much more importantly, to understand the evolution of treatment and how this has really affected our cure rates. And we'll go through what's happened over the last few decades with chemotherapy, more recently molecularly targeted therapy, and then immunotherapy. In my youth, I would have had many more conflicts of interest, but not so many in this day and age. So I love to be number one, but I would really not like to be number one for lung cancer, but it is the number one cause of cancer-related mortality in both men and women in Canada. It causes more deaths than breast cancer, colorectal cancer, and prostate cancer combined, sadly. Of all the cancers diagnosed each year in Canada, about 12 to 13% are lung cancer. Unfortunately, the majority of our patients present, at least 2/3 of them, present at advanced stages, stage 3 and 4, and thus our overall death rates, unfortunately, contribute to a quarter of the death rates in Canada, despite our incidence rates being only a half of that. And of course, smoking is always the elephant in the room, and most cancers are smoking related. But the statistics are looking a wee bit better, I must say, in Canada. Things are improving. And at this point, only 12% of Canadians age 15 and older smoke. And you can see that compared to 25 years ago, when it was over a quarter, we're now down into the 10 to 12% range for smoking. However, there are some very disturbing trends, and these disturbing trends are in our youth, where vaping levels are increasing quite rapidly. And there was a recent article in the CMAJ that reported that almost 30% of students in grades 7 to 12 are trying e-cigarettes, and 10% of them are vaping daily. And they really are being exposed to very high, sometimes very high concentrations of nicotine in the vaping. And you can just see these e-cigarettes are targeting our youth. You can see all these wonderful flavors that they have, but you can also see that some of them have very, very high levels of nicotine and very, very high risks of becoming addicted to the nicotine. And not only that, but the nicotine patches are really being marketed to our youth. And the health minister is aware of this, and I think they're now going to be taking some steps to limit the access of our youth to nicotine. So the takeaway messages from this most recent article is that we don't yet have a full understanding of the long-term effects of e-cigarettes, but there unfortunately is mounting evidence that e-cigarette use also increases the risk of cancer. Although we don't have the toxins that you get from burning tobacco, we really have no idea what the potential negative effects are of all the other things that are in e-cigarettes. And we also have mounting evidence that the nicotine in e-cigarettes, and I put here question mark pouches as well, increases the risk of cardiovascular and pulmonary disease. And this article ended by saying, overall, e-cigarettes may have few benefits as a smoking cessation tool, and the risks associated with their use, including the risk for cancer, require longer-term follow-up and a thorough clinical and epidemiological investigation. Okay, now moving to my journey for lung cancer, I announced at this age, at 5 years of age, that I was going to be a doctor. 10 years later, I was volunteering at the Princess Margaret Hospital. I was a daffodil girl. We wore little yellow uniforms. And here I am at age 16. I was invited to the 10-year anniversary dinner of the Princess Margaret Hospital, and it was quite a spectacular event. at the then Park Plaza Hotel. Now, I hadn't really decided at age 16 when I started to work at the Princess Margaret that I wanted to be a lung cancer, and that came a couple of decades later. And why is that? Well, the reason for that is that my then boss made a very telling statement, and he said, to succeed in research, you have to focus. So why did I focus on lung cancer? Well, basically, I think it's because of these two surgeons, Griff Pearson and Bob Ginsberg. And we had an incredible thoracic surgery division that really served all of Ontario. And we had a huge base of lung cancer patients. And they introduced me first to the lung cancer study group. And then my clinical trials-based career has evolved through the National Cancer Institute of Canada, the NCI US, and the European Organization for Research and Treatment of Cancer. So way back in the 80s, when Dr. Baker told me to focus on lung cancer, which I obediently did, things were desperate. Things were desperate. No one really wanted to treat lung cancer. Everyone wanted to be a breast cancer doctor or a lymphoma doctor. The feeling was, in actual fact, that for advanced lung cancer, no one should be treated. The drugs were too toxic, the response rates were too low, and this is one of the first non-small cell lung cancer trials that were done, and I call these the dinosaur age trials, when we measured the survival in days. Things do get better. But in the 80s, we did many, many trials. And because of the nihilism, we did trials of chemotherapy, toxic platinum-based chemotherapy against best supportive care. And these studies showed that there was a modest improvement in stage 4 cancer by 2 to 3 months, improvement in symptoms, quality of life was okay despite the toxicity of treatment, and it was cost effective. But those curves went down inexorably to ground by 2 years. In the 1990s, we had a whole host of new chemotherapy agents that we called our third generation agents. We still combined all these new agents with a platinum, cisplatin or carboplatin, and we spent the 90s comparing all of these agents to find out if one grouping was better than the other, but there were no significant or meaningful differences. You can see from the survival curves that they all overlap. The benefits are modest. And someone at a meeting said, all these studies were like rearranging the deck chairs on the Titanic. Our most recent agent, though, is pemetrexed, and it really is an extremely well-tolerated drug. And in non-squamous lung cancer, which is the large bulk of our cancers these days, we now have more than a quarter of patients alive at 2 years. So if you just look at this comparison, which is pretty trite, and looking at 1-year survivals, there really actually has been some improvement. This is where I started when we measured the survival in days. These are the trials rearranging the deck chairs on the Titanic. And now we have our best chemotherapy agent, pemetrexed, and with maintenance, we're now looking at our survival rates of well over 50% compared to almost none with best supportive care, and 2-year survival rates of more than 25 or 30%. So stepping back again, now that we've convinced people that first-line chemotherapy works, what happens when the wheels fall off and the cancer progresses? And is there a role for second-line chemotherapy? So in 1997, not that long ago, the ASCO guidelines said, no, there's absolutely no role for second-line chemotherapy. But we continued to study new agents, and docetaxel was the new agent at the time. And for patients who had no other options, we offered them the trial, the TAX 317 trial of docetaxel versus best supportive care. And lo and behold, there was an improvement I mean, these curves are very much separated, and there was a tripling of 1-year survival, and this was highly statistically significant. And 6 years after their initial guideline, ASCO changed its guideline and said that docetaxel is now recommended for second-line treatment. But you might say the modest benefits that we see really aren't worth it. But why do we keep doing it? And my answer to that is we keep looking at treatment in the second-line setting and the third-line setting because we want to move those treatments. They have to be active in advanced disease for us to move them into the adjuvant setting. And this is where I come back to my two great surgeons, Dr. Pearson and Dr. Ginsberg, who welcomed me into the lung cancer study group. And the lung cancer study group was a surgical group mainly that was focused only on lung cancer and doing trials of post-operative treatment. And one of the early trials was lung cancer study group study 772, which means it was started in 1977. And it was BCG immunotherapy versus a relatively toxic and ineffective regimen of cyclophosphamide, adriamycin, and platinum. And these curves don't look so bad. They look almost as good as curves that we get in this day and age, comparing one treatment to another. But the overall survival benefit was not statistically significant. And so this was not adopted. And this trial was severely criticized because it didn't have a no treatment control arm. Now, some of us think that BCG was a no treatment control arm, but it was criticized. And so we were forced to do another trial. 3 years later, the 801 trial was started. And our own Ron Feld was the PI of this study. And this compared post-operative CAP chemotherapy to observation. It was poorly tolerated chemotherapy, and there was poor compliance, and there was absolutely no survival benefit. So what happened in the 70s and 80s with the LCSG trials? They were all underpowered. If that first trial had had twice as many patients, it would have been significant, but they were all underpowered with only 200 patients. The drugs were only modestly effective. There was inadequate supportive care, and compliance was poor due to toxicity. So we continued doing post-operative chemotherapy trials for years on end, all being compared to best supportive care. And there were 52 of these randomized trials done, which did not really lead to a change in practice. However, when you put all the trials together and you do a meta-analysis, there was a 13% reduction in the risk of death with a hazard ratio of 0.87. And in the pooled analysis, this was statistically significant, but the treaters still weren't convinced. So moving next now, I have to give a big shout out to the National Cancer Institute of Canada team, Elizabeth Eisenhower, Joe Pater, Leslie Seymour, and my long-suffering statistician, Qiu Ding. Because in 1989, Dr. Pater asked me to chair the CTG lung cancer site. And I said, okay. And I took over the committee with not a single active trial open. And within 1 year, I had to present for our US site visit, and a year after that to our Canadian NCI site visit for our grant renewals. And Dr. Charles Mortel for the US site visit was the committee chair, and he was an absolute giant in medical oncology. He was a big man too, giant in medical oncology. And to say I was nervous was an understatement, much Imodium consumed. But 1989 was a perfect storm. We had the new third generation chemotherapy agent, vinorelbine. We had a new class of anti-nausea agents, the 5-HT3 inhibitors, which meant that cisplatin could be given as an outpatient. And Burroughs Wellcome was the manufacturer for both vinorelbine and ondansetron, and they were open to collaboration. So for my site visit, this was the clinical trial that we developed to pull the rabbit out of the hat. This was the BR10 trial. This was a North American trial, started in Canada, but we brought all the US cooperative groups in, and this was the first North American intergroup cooperative group study that was led by a Canadian center. And we took completely resected stage 1B and 2 lung cancer and randomized to observation or vinorelbine and platinum for 16 weeks. So just a short 4-month course. And lo and behold, we had a significant survival benefit, hazard ratio 0.7, an absolute difference at 5 years of 15%. And in stage 2, the absolute benefit was 20%. And nothing like this had ever been seen before. Was it a fluke? Could it be repeated? Well, no, it wasn't a fluke. In the big meta-analysis, when they looked at the various drug combinations and the various second and third generation agents that were used in the studies, vinorelbine came out on top with a hazard ratio of 0.80, a 20% reduction in the risk of death. So it wasn't a fluke. It was that we had better agents and we were able to deliver those agents with better supportive care. So BR10 was a landmark trial. It changed the cure rate for resected lung cancer, and it changed practice at a global level. But the state of the science also has changed since we had that trial. Back in 1989, we were sequencing oncogene by Sanger sequencing. We had to have frozen tissue. KRAS was the oncogene du jour, and it was reported to be a marker of poor prognosis and was pretty common in lung cancer, around 30% of our patients. So the other rabbit that we pulled out of the hat for our site visit was that our trial was the first trial to have a prospectively collected tumor bank and the first trial to be stratified by an oncogene. So we stratified by KRAS positive or negative. And Ming Chow, who leads all of our translational research study and chaired the translational committee for the NCI for many years, reported that KRAS was not really a strong prognostic marker, weakly prognostic of poorer outcome, but in the subgroup of patients who had KRAS mutations, they had absolutely no benefit from the adjuvant chemotherapy. Now, because we had this large trial of platinum-based adjuvant chemotherapy, we were invited to join the LACE and the LACE Bio collaboration. LACE was just the pooled analysis of all the platinum trials looking at the clinical outcomes, but 4 of the groups had associated tumor banks. And we decided to get together and to pool our resources so that we would have the proper statistical power to do individual oncogene marker studies. And the nice thing about it was that the statistical center was in Paris at Gustave Roussy, and we never met by Zoom. Of course, we always had to go to Paris for our meetings, which we did at least once a year. So when we looked at the pooled analysis of KRAS, we were able to look at subtypes because all KRAS mutations are not the same. There are different subtypes in different cancers, and there are different mutation subtypes that vary by smoking status. So what we found is that for the major KRAS on codon 12, those mutations, once again, absolutely no survival benefit. But much to our surprise, when we looked at the very small 10% subset of codon 13 mutations, this is the supportive care arm. This is the no treatment arm. And there was actually a negative effect of chemotherapy in this subgroup. Now, KRAS is one of our most frequently mutated genes, but not the most frequently mutated gene, which is TP53. So in our LACE Bio, we were able to look at TP53. It is not at all prognostic, mutation or no mutation, But once again, when we looked at the benefit from chemotherapy, the benefit was limited to the patients whose tumors were wild-type TP53, and the hazard ratio, once again, is above 1 in the mutated subgroup. The interaction p-value here is borderline. Even with our pooled analysis and hundreds of patients, we still only had a borderline significant interaction p-value. So then we looked at both KRAS and TP53 mutation. In truth, TP53 is the only one that's frequent enough that we can put together to look at co-mutation. And once again, we found that the survival benefit was limited to the wild type. And if you had both KRAS and TP53, this once again, I'm afraid, is the observation arm, and the hazard ratio was 2.44, very negative effect with dual mutations. We then came back, and around this time, we had a whole bunch of Francophone fellows, and they really had a great time together. But Pascale Tomasini, and we're seen here at her wedding in the south of France, looked at our more advanced disease patients who were treated with chemotherapy here at PMH. And once again, the best outcome was for the wild type groups. And if you had either a single mutation or a dual mutation, you did not do as well. And this little one was born when she was, her mom was a fellow with us. So the science and the technology has continued to evolve. And in the 20s, we could do whole exome gene sequencing. And now in the 2010s and 2020s, we are able to even find the mutations from ctDNA in the peripheral blood. So because of this, with the Lace Bio group, we applied for and got a US NCI R01 grant. And this was led by Dr. Leslie Seymour. And we did whole exome targeted sequencing for all the patients in the Lace Bio group. And we looked at their tumor mutation burden. And somewhat surprisingly, actually, the patients with the highest tumor mutation burden had the best outcome. I'm not sure we really have a good explanation for that. It may be that maybe they're more immunogenic and your own natural immunity sets in, but this was almost a counter observation to what we had expected initially. But in contrast to that, the patients with the highest mutation burden did not benefit from adjuvant chemotherapy. This was a new observation and totally surprising to us, and not entirely explained to this day. So lung cancer is one of the most highly mutated cancers. It's second only to malignant melanoma. But most of the mutations, the gene mutations in lung cancer, are not driver mutations. But we are somewhat lucky that we have been able to identify several driver mutations that are targetable and treatable. So let's move on now to our targeted treatments for lung cancer, which is where the fun really begins. So KRAS is one of our most frequent mutations, and until recently, we didn't have any KRAS targeting agents. But EGFR is mutated in the Western population about 10%, and the Asian population about 40% of the time. We have molecularly targeted treatments available for all of these targets, and we now have about a dozen of them that we can treat in lung cancer. So we've known that the EGFR pathway was important in lung cancer for many years. And when we talk about EGFR, it's EGFR1. When the breast cancer docs talk about EGFR, it's EGFR2 or HER2. But EGFR in lung cancer is very important. It drives proliferation, invasion, metastasis, and angiogenesis. It's frequently expressed, and when I say expressed, I mean at the protein level. It is expressed at the mRNA level, of course, as well, and often with high gene copy number. And so there was great interest in targeting the EGFR pathway, and numerous treatments were developed, monoclonal antibodies, initially the oral TKIs, and more recently, antibody drug conjugates. But the most interesting part is the story around the oral TKIs and EGFR. So going back to our dinosaur days again, the NCI trial BR21 was a trial for patients who had had first-line treatment, second-line treatment, and had no other options. And the study randomized these patients to the EGFR TKI, the first generation TKI, or erlotinib daily, or placebo. And you'll see in the yellow that there was no EGFR selection. Why did we do that? Well, we did that because we thought it would slow down accrual to have to get the sample sent to a central lab. EGFR was expressed in 90%, and we could just power up a little to account for the other 10%. And so that's what we did. In naivety, I will say. But lo and behold, naive and all as we were, this was a positive trial. Hazard ratio 0.7, 30% reduction in the risk of death. And this was another landmark trial from the clinical trials group. It led to back-to-back publications. We got 2 publications out of it back-to-back at the New England Journal with the clinical presentation and the Ming's molecular analyses. It was another landmark trial. It led to the approval of third-line erlotinib, and once again, it had a tumor bank. We really have focused in the clinical trials group of doing translational research and having a mandated tumor bank with all of our studies. So around the time that the first generation EGFR TKIs were being evaluated, we all noticed that there was a small subset of patients who had Lazarus responses. And their X-rays and CT scans could go from something that looked like panel A and C to panel B and D in a short number of weeks, and their symptoms would disappear within 1 to 2 weeks. So that led several groups to analyze and sequence the tyrosine kinase domain of EGFR. And what they found when they looked at those patients with the miraculous responses were that they had driver mutations in exon 19 and point mutations in exon 21 L858R. And when Ming looked at our biomarkers from BR21, you can see that the best hazard ratio was in that small subset of patients who had these exon 19 or 20 mutations with a hazard ratio of 0.55. And for those who had KRAS mutations, our old friend here, the hazard ratio was once again above 1. And it's well known now that the presence of a KRAS mutation is a negative marker for EGFR inhibitor therapy in general. So who are these people who have these EGFR mutations? Well, they're females. They all have adenocarcinoma. Many of them are Asian, and many of them are lifetime non-smokers. Doesn't seem fair to get cancer when you're a lifetime non-smoker. But in actual fact, 30% of women with lung cancer are non-smokers, and about 10% of men are non-smokers. And 50% of our patients overall are former smokers. So this led us to come back and just look at our database here at PMH. And Greg Corpanti, who is one of our fellows, looked at over 700 patients in our database who are lifetime non-smokers. 50% of them had EGFR mutations. Only a quarter had no mutations at all. And then our next most frequent mutation is ALK, and we now have targeted therapies for ALK as well. So the next thing, we could introduce these EGFR TKI therapies at the second and third line, but the next step was to compare them to chemotherapy in the first line setting. And it didn't matter what chemotherapy regimen you used, and it didn't matter what EGFR TKI you used. There was always a superior outcome for the TKI over chemotherapy. And so now EGFR TKI therapy for EGFR mutated lung cancer is our standard first-line treatment. Now, with the first and second generation agents, the mechanism of resistance was the development of a resistance mutation of T790M. And osimertinib was introduced as a T790M inhibitor. And osimertinib is very interesting because it's better tolerated than any of our other agents, has a higher response rate, longer survival, and is really a very, very nice agent. But the first trials looked at second-line osimertinib versus platinum, and osimertinib blew them out of the water. Look at the hazard ratio for progression-free survival of only 0.30. But the next step was to look at first line, move it out of the second line in T790M mutated and move it into first line for all EGFR mutated lung cancer and compare that to the first and second generation TKIs. And once again, osimertinib was superior. So this is now our first line treatment of choice. And just look at where we were back in the dinosaur days. That's our 1-year survival. And look at where we are now with our targeted therapy with osimertinib. So, you know, this is real progress. Identifying the target and targeting the target leads to a much better outcome. But remember, I'm after the cure rate, not just prolonging survival for a few years. And we've moved osimertinib into the adjuvant setting in both stage 3 and early resected stage 1 and 2. So our stage 3 lung cancer, and that spread into the mediastinal nodes, is not operable, and it's treated with chemotherapy and radiation with maintenance immunotherapy. But we've pooled our resources with a group at Yale, and we have sent them all our data for our EGFR mutated lung cancer stage 3. And we have compared, and this is not a randomized trial, this is just a retrospective search, looking at the survival for patients who get maintenance EGFR TKI. And you can see it's very, very much better than our standard of care of no maintenance or immunotherapy. We do not have EGFR TKI maintenance therapy, though, approved and paid for in our country. Now, moving to earlier stage, the phase 3 ADORA trial looked at post-operative, so early stage 1 and 2 lung cancer, totally resected. And this study was interrupted by the Data and Safety Monitoring Board because of these amazing results in the active osimertinib treatment arm. So it was interrupted early. We had to wait a few years for the final survival analysis. But you can see here that the hazard ratio for death was 0.49, statistically significant. And at the 5-year mark, look where we are, we're at 85%. When you target the proper target, you get the good results. Now, ALK is our next most frequently mutated, about 5 to 7%. And just looking at ALK in the stage 3 setting with maintenance ALK TKI therapy, and once again, we do not have this approved in Canada, so our contribution is no TKI therapy actually to this analysis. And just look at this survival curve. It's flat at 100%. Now the numbers are small, but I mean, this is really very encouraging. And there are randomized trials of EGFR TKI and ALK TKI maintenance ongoing. So I'm assuming that very soon we will have approval and funding for maintenance in the stage 3 setting. ALK TKIs have also been looked at in the post-operative adjuvant setting. And once again, huge progression-free survival benefit. The overall survival hasn't been reported yet as it's too early. And a very important point, freedom from brain metastases. These molecularly targeted cancers have a very high incidence, 50 to 60% of brain spread. And many of our TKIs, both osimertinib for EGFR and alectinib for ALK, have very, very high brain penetrance. So freedom from CNS disease is very important for us. So we have some challenges, though, in our healthcare system. We have EGFR TKIs for advanced disease and for post-op adjuvant treatment paid for. We have ALK TKIs in the advanced disease setting, but not the adjuvant setting. We have paid for drugs for ROS1, but we have no paid for or covered drugs for any of the other driver mutations for which there is really documented evidence of benefit. So we're a little bit behind there. And now I'm just going to move to immunotherapy, and I'm not going to show you all the first line and the second and third line trials, but really move to the adjuvant setting. So immunotherapy is an old concept made new. So I started my training at the Toronto Western Hospital doing immunotherapy trials of BCG with Dr. Baker. That didn't work out so well. Then moved into the BCG trials of the lung cancer study group. That didn't work out so well either. And I have participated in and been an observer to many, many, many trials of various immunotherapy strategies over the years that never have worked. And quite frankly, I never thought they would work. And there was enormous pessimism. And just to show you, this is the Lung Cancer Study Group 771 trial of post-operative BCG versus placebo. What had been observed was that patients who developed an empyema after their surgery seemed to do better than those who didn't. And the thought process was that, the immune system was stimulated by the empyema, and the immune system was taking care of micrometastatic disease post-operatively. And that if we could stimulate the immune system with BCG, then that would be as good as an empyema. Well, it wasn't. This was clearly a negative trial. But just to show you that Dr. Baker, in his early career, was a lung cancer doctor, here are some of the immune studies that were done out of that early lung cancer study group. And there's old Dr. Baker. I'm hoping by the end of my talk, he regrets not doing lung cancer and staying in lung cancer. It's so much fun these days. So the immune checkpoint inhibitors, all of our studies were really designed initially at revving up the immune system by one way or another, and all of them were negative. Our focus now, though, is more on the effector phase of the immune system and on the part of the immune system that keeps the immune system under control. And we call that the checkpoint inhibitors, or the checkpoints of the immune system, because we don't want the immune system to go haywire. And the checkpoint inhibitors are targeted against the checkpoints, and they take the brakes off the immune system and allegedly allow the immune cells to attack the cancer. And we have four approved checkpoint inhibitors, 2 anti-PD-1 and 2 anti-PD-L1 inhibitors that are all approved for lung cancer. And I think it's kind of interesting that the checkpoint inhibitors have such a great role in lung cancer at all stages now, when you look at that mutation spread and see that they're highly mutated cancers. So I think, and melanoma as well responds to the checkpoint inhibitor. So it does have something to do with the immune system and the mutations. And if we can activate the immune system, take the brakes off, there may be a benefit. So the Pacific trial is in stage 3. I'm just focusing on the curative state here. Stage 3, mediastinal nodal spread, treated with chemotherapy radiation. And this Pacific study randomized to durvalumab, which is an anti-PD-L1 inhibitor, for a year. Initially, we gave it every 2 weeks, but now monthly, versus placebo. And you can see that these curves are widely apart. These are statistically significant differences. These are clinically meaningful differences. And even in the updated now, we would have expected actually a 15% survival in our early days of treatment for non-small cell lung cancer. And now at 5 years, we're up over 40%. So moving into the earlier stage, the completely surgically resected, stage 1B, 2, and 3A. This is the Empower 010 trial of chemotherapy. All patients had to have their 4 cycles of chemotherapy. We haven't abandoned that. It works. But then adding in the PD-L1 inhibitor, atezolizumab, every 3 weeks for a year. And the progression-free survival benefit was positive, hazard ratio 0.81 in the intention to treat population, significant, p-value 0.04. But when we looked at the subgroup that had positive PD-L1 expression, and we measure this simply by immunohistochemistry of greater than 1%, the hazard ratio was very much better at 0.66. But woe was us when the overall survival results came out, because there was no benefit to the adjuvant atezolizumab. And this is a $10,000 a month drug. But atezolizumab is a targeted therapy. It targets PD-L1, and yet we didn't select in this study for PD-L1. So what happens if you select for PD-L1? Stage 2 to 3A PD-L1 greater than 50% expression, hazard ratio 0.42. Any expression 1 to 49%, hazard ratio only 0.95. And no PD-L1 expression, hazard ratio above 1 at 1.36. This is targeted therapy, just like our TKIs are for mutations. It's targeted therapy. If you don't have the target, the patients won't benefit and potentially might be harmed. So you got to love our American cousins. Despite this, the FDA has approved post-operative adjuvant atezolizumab for all patients with greater than 1% tumor cell expression. Canada and Europe are more conservative. They have approved for greater than 50% PD-L1 expression, and we're still in a negotiation to get the price down. The CADIT approval was with the requirement to reduce the price by 24%, so that our ICER, the cost per year of life gained, would be in the $50,000 range. And to this day, we actually do not have post-operative atezolizumab reimbursed. There are more trials to come of adjuvant PD-1 and PD-L1 inhibitors. These 3 are all cooperative groups. This is the Roche one. They could get there faster because they had all the money to run all around the world to do the study, but we're waiting for the results from the cooperative group trials. So my lessons: clinical trials aren't for sissies. Don't be discouraged by negative results. Lung cancer study group never had a positive trial, but we kept plugging away at it. Tumor banks really are key, and translational research requires collaboration. Collaborate with people in fabulous places, because then you get to go and visit with them. And we really have been collaborating around the world. We have now identified critical pathways for lung cancer. We can now specifically target these pathways with driver mutations and the immune pathways, and patient selection by genetic analysis leads to improve outcomes. So lung cancer is not golf. It's a team sport. We have a huge and very, very talented lung cancer team here of medical oncologists, radiation oncologists, and our surgical group, of course, who bring in all the lung cancer patients to us. We've had a wonderful, wonderful donor support, and we have 5 chairs now dedicated to lung cancer research, and a couple of fellowships, and a screening program, all thanks to donors. But my biggest thanks have to go out to Ming Chow. I call Ming and I the dog and pony show, but I'm really the little dog riding on his shoulders. He's taught me everything I know about molecular biology. So thank you, Ming. And our pathologists and our molecular pathologists really are the rock stars of medical oncology. We cannot start treatment anymore without a full molecular profile. So I will end again by thanking Wendy. I'm sad she's not here actually to see that I photoshopped. She had a little bug on her lapel, and I have replaced her bug with her nice Order of Canada pin. So thank you all.
Wonderful. Thank you, Frances. Just to remind you all, there is a evaluation that you can register your attendance for credit. And at this point, why don't we open it up to questions? There were a couple comments in the chat. Michael Baker said, how did you manage to evolve from busy clinician to innovative clinical molecular biologist? Jillian Hawker says, what a fantastic story of a highly successful academic career and major innovations in lung cancer treatment. Thank you, Frances. Others, Joss has said, where are we with small cell cancer and squamous cell CA, which is what Frances didn't want to talk about.
I didn't want to talk about that, no.
Pumping it over to you.
Well, let me answer the small cell question first. Dr. Baker's question, I think, would be a much longer answer. But anyway, small cell used to be about 20%. It's now down be about 10% of all of our lung cancers. In the 80s, all the excitement was for the new drugs for small cell lung cancer, and etoposide and platinum remain our standby. We have not changed the chemotherapy for small cell lung cancer in 30 plus years. There have been advances in small cell lung cancer with the addition of thoracic radiation and prophylactic cranial irradiation, and that has changed survival. Small cell lung cancer, quite unexpectedly to us, does not express PD-L1, but the PD-1 and PD-L1 inhibitors have been evaluated with modest, very modest benefits from the addition of atezolizumab, the PD-L1 inhibitor. But I wish we had made the progress in small cell that we have made in non-small cell. And most of our progress in non-small cell is in adenocarcinoma, where all these fabulous driver mutations are.
Frances, perhaps I can ask a question. You had mentioned that the effectiveness of the ALK TKI agents in suppressing brain metastases,
Yeah.
right? And is that because of the effectiveness of the drug in neural tissue, or is that more of a transport issue? That is, they have access across the blood-brain barrier.
You know, we've talked for years about this blood-brain barrier and that the drugs can't get up into the brain because of the blood-brain barrier. But we're not entirely certain that that is a true concept. And in actual fact, we have seen responses in small cell lung cancer in particular. I've seen responses in the brain to etoposide and platinum chemotherapy. So I'm not entirely sure whether the brain really is a sanctuary site. But for the TKIs, most definitely it has to do with the nature of these small molecules. They are small molecule TKI inhibitors, and they do cross into the brain, and you get very high brain, and when it's been measured at CSF levels. Now, interestingly, immunotherapy acts in the brain as well, and we can see response to our immunotherapy agents. And you would think to yourself, oh my God, but how can a big monoclonal antibody get up into the brain? Well, my answer to that is it's not getting up into the brain. The monoclonal antibody is not actually attacking the cancer. the monoclonal antibody is taking the brakes off the immune cells, and it's the immune cells that are floating up into the brain and causing the responses. So I don't think the monoclonal antibodies actually get there, but we do see responses to the TKIs and to the immunotherapy, not infrequently. So much so for EGFR and ALK now, and many of our patients present with brain metastases. And if they're small and asymptomatic, we don't treat them. We just give them the TKI now, and we follow them closely with MRI, and almost all of them respond. They respond. And we save the radiation for, when the wheels fall off down the road. And we can sometimes save them from radiation and whole brain radiation for months to years.
So another quick question. We're just about to wrap it up. So I'll ask the first of Christine's two questions. In the era of new era costly medications, and this is applicable across medicine, do you think it's best to direct the advocacy appeals to the companies to scale down the prices of drugs, or to the insurance companies to scale up the generosity of coverage? So as a cancer researcher and clinician, how would you look at that? Where do we put our advocacy efforts?
Well, every new cancer treatment that comes on board has to go through the CADTH evaluation process. And that's open, and those are all posted online. You can read the CADTH reviews of all of the drugs. But then there's a black box. There's a big black box. And we don't know what goes on in the black box. And that's when the companies negotiate their prices. And there is absolutely no doubt that the companies do scale down their prices in Canada. We cannot pay the prices, nor can Europe for that matter, pay the prices that the US private insurers will pay. So the prices in Canada are all scaled down. It all happens in the black box. But the price is calculated on a price per year of life gained.
Wow.
And if that's too low or too high, the price is too high, it just doesn't get approved for us. And some of the trials that have been done that lead to approvals in the US are just single arm trials where we see response rates of 80%, which is wonderful. But there's no randomized data. So you can't have a cost per year of life gained if you don't have randomized data to compare it to another standard treatment. And that is another way that we have been denied. That was the way we were denied BRAF inhibitor therapy in lung cancer. It's not approved for us. We maybe need more patient advocates at the table. I mean, if you've got an 80% response rate, you've just got to have the treatment.
Yeah. Thank you. And on that note, I wish we'd go on. I just want to point out Frances Jackie's tribute to you, given her father-in-law's marvelous response to your treatment. It's in the chat. But otherwise, thank you, everybody. And again, thank you, Frances. This was a wonderful talk and just a great honor to have you. Thank you.
Okay.
Please take care.
Bye-bye.
See everybody soon. Bye-bye.